Hey y'all, I'm Tammy Norville, CEO of the National Organization of State Offices of Rural Health. Happy National Rural Health Day! I hope you're having a fantastic day celebrating the amazing rural rock stars across the country. At NOSOR, we created the National Rural Health Day celebration back in 2011 to celebrate and elevate these folks and the positive and unique characteristics of rural health. We help state offices of rural health help rural providers, patients, communities, and neighbors become and remain more well. These incredible individuals dedicate themselves to serving their neighbors and advancing the power of rural every single day. Thank you so much for joining us as we continue the celebration with an inspiring lineup of experts from the Rural Communities Opioid Response Program, or RCORP, arena. They're here to share powerful success stories and innovative strategies that are making a difference in rural communities nationwide. I'm excited to introduce our expert panel. Megan Meacham is the Director of the Rural Strategic Initiatives Division at the Health Resources and Services Administration. Tedra Cobb, president of Tedra L. Cobb and Associates, with expertise in program development and interactive educational workshops. She's also a consultant trainer for the University of Rochester Medicine Recovery Center of Excellence, working nationwide to reduce stigma and address substance use disorder. Kim Schuler, Chief Executive Officer of the Arkansas Behavioral Health Integration Network and Community Star, leading efforts to improve behavioral health integration in rural communities. So if you have questions for our panelists, feel free to drop them in the chat. If we run out of time to address them during today's session, you can email your questions to info@powerofrural.org. That's info@powerofrural.org. Once again, thank you for joining us. A huge shout out to our expert panelists for generously sharing their time and knowledge and experiences with us. And with that, it's my honor and pleasure to hand things over to Megan, Tedra, and Kim.
Thank you, Tammy. I'm just getting my slides shared here. Thank you so much, Tammy. That energy, I love it. That is the perfect energy to bring into National Rural Health Day. Happy National Rural Health Day, everyone. We are such a proud partner in helping to celebrate National Rural Health Day every year since 2011, when NOSOR created the day to celebrate. It's kind of become a week for our office. And we're so pleased that you chose to spend your day here with us. And before I talk a little bit more about RCORP specifically, which is what we're here to talk about, I do want to just give a quick little intro into the Health Resources and Services Administration and the Federal Office of Rural Health Policy, just in case you're not familiar with the work we do. So HRSA is an agency of the Health and Human Services Department, and the mission of HRSA is to improve health outcomes and achieve health equity through access to quality services, a skilled health workforce, and innovative high-value programs. So through HRSA and our multiple bureaus and offices, we serve tens of millions of Americans to ensure that they have access to quality, affordable health care. We administer more than 90 programs and serve more than 3,000 grantees across the country. And some of the programs that you may be familiar with that are run and administered out of HRSA would be the federally qualified health centers. There's the Maternal and Child Health Bureau, Healthy Start programs, and many others. The health workforce programs, such as the National Health Service Corps and other loan repayment programs, the HIV/AIDS Bureau, and the Ryan White Block Grant programs, among others, and then our Office of Rural Health Policy. And then there are also other small bureaus and offices within the agency. So if there's something to do with public health, chances are we're probably touching it in some way. And then the office that I'm in is the Federal Office of Rural Health Policy. And we have a really interesting office. We have a dual role. So we are in the Health Resources and Services Administration because one of our roles is program administration. We provide grants and cooperative agreements out to rural communities to help improve access and healthcare in rural America. But we also have a second role, which is really to be the broader voice for rural across the department. So we do this by advising the Secretary of Health and Human Services of the impacts on healthcare in rural America. We partner with our other agencies within HHS and beyond, even other departments such as USDA. And then we also fund and conduct rural health policy analysis and rural health research in our office. And so what's really neat about having this dual role in one office is that we're able to have the research and policy role help inform our programs, and then vice versa. We're able to learn from our programs and what grantees are doing on the ground to help inform our policy analysis and our research. So now to tell you a little bit more about RCORP specifically, it truly is just, it's so rewarding to work on this program. RCORP is the only large-scale rural-focused federal program addressing substance use disorder and opioid use disorder. And it was created as an innovative response to the public health emergency, the opioid crisis. And it was really created in 2018 as a cross-agency response to this public health emergency. So while it's housed in the Federal Office of Rural Health Policy, and it's a program that serves rural communities, we work with our partners in the Bureau of Health Workforce to make sure that workforce is accounted for in our program. We fund a number of health centers and are working with our Bureau of Primary Health Care. We know that individuals who use substances often have higher risk of HIV and AIDS because of needle use. So it really is a cross HRSA response to this opioid crisis, which has been really rewarding. And the initiative was also created keeping the varying needs of rural communities in mind at the forefront of everything we do. And 7 years in, so the initiative was created in 2018, and now in our 7th year, we continue to really allow rural communities to address the specific needs that they're facing by allowing flexibility as the crisis continues to evolve year over year. So a couple of other important notes is that RCORP is the single largest line item in the Federal Office of Rural Health Policy budget. In FY24, our appropriation was $145 million of the 360 or so of the Federal Office of Rural Health Policy. And it's also a really neat program because we've continued to have bipartisan support to address behavioral health and substance use disorder across multiple administrations. We fund a number of resources for grantees and publicly available resources, and there's a lot of activities going on. Our grantees are making life-saving impacts and transforming access to substance use disorder and behavioral health care in their communities, like you'll hear from Kim later. And then also just the innovative rural-specific resources and activities that are being conducted out in rural communities, like you'll hear from Tedra. This is just a snapshot of kind of more of the performance data that our grantees are providing us. And this is the, what our grantees accomplished in just one fiscal year, one grant year. So our core grantees hired more than 330 new providers, like new to providing behavioral health services in rural communities. More than 2 million individuals received direct prevention, treatment, and recovery services from RCORP grantees. 112,000 individuals received medication-assisted treatment through RCORP grantees, and more than 138,000 rural behavioral health care providers and paraprofessionals have been trained in topics such as reducing stigma and naloxone. So this is some of the programmatic data that we see each year from our grantees to show the impacts, but equally as important are the stories that we hear from our grantees and the individuals that are directly impacted from this funding. And I think it's so important to see these testimonials and the direct impact of the lives changed and saved through RCORP over the past 7 years. We've heard so many stories of the individuals who have been able to re-enter society after incarceration and be connected with services so that they could sustain long-term recovery. We've heard stories of high school age children having their lives saved because our RCORP grantees were able to put naloxone in the schools and respond to an overdose event. We have communities that are building out the wraparound services and supports that didn't exist prior to the RCORP funding in their communities. And then just establishing new prevention, treatment, and recovery services where none previously existed as well. So this is one example of just a really heartwarming testimonial that we are fortunate enough to hear pretty frequently. And then this is another community that was able to establish a new recovery center and provide residential treatment and wraparound services in a very rural area that didn't have access to these residential treatment and recovery services prior to the funding. So as you can see, these grants, this funding is really having a very real and direct impact on people's lives and their ability to attain that long-term meaningful recovery. Before I pass it over, I just wanted to share a few resources that we do have available if you'd like to learn more about any of our grantees or our resources. So all these slides will be shared, so I'm going to breeze through them a little bit quickly, but we do have RCORP grantee directories available on RHI Hub. So if you're interested in learning more about what any of our grantees are doing, feel free to go and check out the grantee directories, and there's a lot of them have contact information. So if there's something that you want to try to replicate in your community or learn more about, you're able to reach out. Through RCORP, we also fund a technical assistance provider. And while the technical assistance itself is only available and offered to RCORP funded grantees, all of the resources that they put on their website are publicly available. So there are a ton of resources, webinar recordings that are available. So I would encourage you to check out the RCORP TA resource portal. We also have 3 rural centers of excellence, of which TEDRA is affiliated with one. And so one is on focused on prevention. That's at the University of Rochester. We have a center of excellence on treatment. That's at the University of Vermont. And then a center of excellence on recovery with the Fletcher Group. And collectively, they work together to build the evidence base for effective prevention, treatment, recovery interventions in rural. And they've also collaboratively put together and launched just this summer the Rural SUD Info Center. So this is where you're also going to find just a ton variety of resources on prevention, treatment, and recovery, best practices and evidence base for rural substance use disorder. I absolutely cannot talk about RCORP without highlighting this wonderful team. There are 23 of us in the Federal Office of Rural Health Policy that are specifically working on RCORP. That is a lot of people, but that is how many people it takes for us to administer this program and give our grantees the support that they deserve and need. Could not do it without this dedicated team of humans. Just a little bit of information. If you'd like to learn more about our programs, please go to the HRSA.gov website, the rural health page, and there's an opioid response page. It can link out to all of our programs. And you can feel free to reach out to us. The rural opioid response at HRSA.gov is a joint inbox to be able to access us and contact us with any questions. Please, if you don't already, sign up for the F4HP weekly announcements. It will put an email in your inbox every Thursday with the newest funding opportunities, the newest news, the newest policy updates, anything that you might need to know about rural health. We try to get in this weekly announcement. And finally, HRSA is always looking for grant reviewers, and selfishly in our office, we're especially always looking for grant reviewers who know and understand rural and can really review grants from that rural perspective and lens. So there's some slides in here to talk about that, to show you how to become a HRSA grant reviewer. It's also a really great opportunity to see the grant review process from the other side, and see strong grants and see how the process works if you also are interested in applying for grants. So this is the links that you would choose for that, or use for that, sorry. And with that, I would like to turn it over to Tedra.
Hey, Megan, real quick, while Tedra's getting her slides
Yep.
up, there was a question in the
Sure.
chat. Are any of these grants available to NGOs in the CNMI?
So all of our grants are available to any public, private, for-profit, nonprofit organization. Every grant program that is posted, that when the notice of funding opportunity comes out, there will be a specific section on eligibility. And if there are any further questions as the programs are posted, you can always reach out and ask. And Kate, these slides will be shared, correct?
Yes, they will be.
All right. Thank you.
Okay,
Thank
did
you.
I do this right?
I see your
Looks
slide.
perfect.
You guys can see everything. Awesome. Perfect. All right. I'm Tedra Cobb and I'm honored to be here. And I just wanted to follow up something that Megan said about rural America. Not all of rural America looks the same, sounds the same, right? So I think one of the things that's so important about the work that everybody is doing and that we're doing at UR with rural communities is supporting the work that we're all doing on the ground in our own communities. So I just sort of kind of wanted to follow up on that thought. I am a consultant to UR Medicine in the Recovery Center of Excellence. And so Megan already gave sort of an overview here, but I wanted to, oh, what's happening? Oh, there we go. I just wanted to put together just a little overview. Again, the Center of Excellence at UR Medicine. I'm multitasking here. In Vermont, UR Medicine Recovery Center of Excellence, the Fletcher Group, and then of course our shared work that we do, the Info Center. And I see Michelle Herman put a link to that in the chat. Michelle's one of the stars for RCOE, the University of Rochester. What I'm going to do today is going to be very speedy. I am going to, something's happening where I can't forward my, oh, I got it. I'm going to share today about the community conversation on opioid use disorder. So I've been working with UR Medicine for a little over 3.5 years, and we have been working in communities to facilitate community conversations in rural places. And what we believe is that ending stigma starts with a conversation. So in front of you, you see portraits, you see some artwork of people. We have a workshop, and today what we're going to do is we're going to go through the workshop. I'm going to kind of give you a taste, and I'm going to let you watch one of the videos. But we use video interviews with people in recovery as jumping off points to learn about and to understand substance use disorder, right? And to understand that the path in addiction is not the same for every person, and that the path in recovery is not the same for every person. But we all have the mission of supporting people in their recovery journeys. So today, what I'm going to do is talk about what we're doing in community conversations, what the community conversations workshop looks like, and give you just a taste of that. I also want to say that when I go to communities, I did health work I've done health work for a really long time, and it used to be that we thought one and done. You do a workshop and la la, we all change our behavior. And what we now know is that doesn't happen. And so one of the things that we've done is we've trained people around the country, and now we have over 600 trained facilitation leaders around the country who are continuing the community conversations after the work that we're doing when I'm there in a community for the week. And then we support all of those facilitation leaders. So I'll talk about all of that, but I'm going to kind of give us a walkthrough of what the community conversation looks like. So it starts with an introduction to all of these folks from around the country. And so in these portraits, you see people from South Carolina, from Kentucky, from Nogales and La Frontera in Arizona, from Seneca, from Salamanca and the Seneca community in New York,
and from some folks from the deaf community in New York State as well. So again, a diverse group of people have shared their stories, and we're sharing those in this workshop. So the first thing we do is we start with a video. This is a teaser. You're not going to watch the video, but what we do is we start with a video, we hear from people, and then we start the conversation. So what we do is we start with this. Every workshop starts with the video and then asking this group of people who have walked in the room thinking, oh, it's going to be a lecture. And we're turning that on its head and saying, this isn't a lecture, it really is a conversation. So after that video, we open it up to the group and we say, if you were having a conversation with each person, what would you want to ask? And this is the opportunity to get people to start to share what they know, to start to share their thoughts, to learn from other people in the room. And then because of the video and what people are sharing, we start to dig in a little bit about learning about the roots of stigma, the roots of addiction, the roots of recovery, right? And how do we help and support people? So we watch that first video, then we have a conversation. And this takes the whole workshop, just so you know, takes about 2.5 hours. I always say give it 3 hours because by the time people roll in, we do a pre-survey, right? We give people about 3 hours for this full workshop. So now we've started the conversation. People are warmed up. They're feeling comfortable. We get people out of their chairs and we do an activity. And so lots of you have probably done a poll before, but what we do is we get people into sort of the center of the room and we say, if you strongly agree, you'll move over here. If you're not sure or you feel like you're kind of in the middle, you'll be in the middle. And if you strongly disagree, you'll move over here. So visualize this with me. And what I'm going to do is I'll post the first one. So we start with opioid use disorder is a medical illness like diabetes, arthritis, and heart disease. And people will move strongly agree, somewhere in the middle, strongly disagree. And then we'll process that. This is an opportunity for me or any of our facilitation leaders to learn about what the people in the room know and to rely on the people in the room to share with one another. So when we're offering these workshops, I always say cast the net wide. We want people with lived experience. We want families. We want providers. We want EMS, fire, rescue, people from the justice court, superintendents, people from the faith community, elected officials, right? So I've had parents bring their teenagers, which is always amazing and makes me so happy. So that's the first question. Once we've done this first question, we say, okay, strongly agree, somewhere in the middle, strongly disagree. People with opioid use disorder or substance use disorder. You can tell that I'm teaching new language just by fielding these questions. People with opioid use disorder or substance use disorder should be able to stop using on their own. I'm going to pause. These are provocative questions because I trust the people in the room to see that there's some problematic, like the word should. Should is judgmental. Stop using on their own is dangerous, right? So I can share a story about my brother who not only drank alone, but tried to stop alone and really almost died because of that. So these questions are provocative to get people to share and to think and to identify what's stigmatizing. So it's really important for me to draw attention to that. Okay, the next one, people who've recovered from opioid use disorder still can't be trusted. So now I know I can't see you, but I know your brains are working and you're saying that word recovered, not so sure. You're right. This is where we get to open up the language of recovery, in recovery, on a healing journey, right? In long-term recovery, and that the language of recovery belongs to the person in recovery. And so we're opening that up. We're helping people to understand language. And the other problematic thing here is trust, right? Still can't be trusted is problematic because we're saying stigmatizing, right? So we're getting to stigma in a roundabout way by getting people in the room to say, I don't like that idea of not trusting somebody with substance use disorder. There are people that don't have substance use disorder that I don't trust. Beautiful. And I always call this when I'm training facilitation leaders, trust the wisdom of the group. People in the room will identify what is wrong without us lecturing. They get to it through the conversation. And then the last one is medications for opioid use disorder, MAR, right? Medication assisted treatment. Replace one addiction with another. This gets us to get that conversation about medications, what people are hearing, what they're seeing, what their stigmatizing beliefs might be, what they might not know, and we're filling in those gaps. So you can see it's a conversation that we're facilitating through this activity. Once we're done, people are tired, their brains have been stretched, they're not used to talking. They thought this was going to be a lecture. So usually we give a break and then I pull everybody back together with this slide. And this is literally the only slide that we read. Our experiences are part of the learning process. We've been learning from one another so that we can provide support. And we've been sharing and focusing on recovery-oriented approaches to overcome stigma. We've been person-centered. We're building on resilience and strength. And in our workshop, we've used interviews, we've used art, and we've used sharing stories. Okay, so the next thing we do is we get to the root of stigma, and you can see the dominoes in the background here. So what I do is I break people up into small groups. One group has perception, one group has bias, one group has prejudice, and one group has stigma. And what each group does is in a small group, whether it's 2 people, 4 people, 5 people, is they talk about the word that they have. What does the word mean? Where does it come from? What's the impact of this word? And then we take those huge sticky easel papers, we put them up in the order perception, bias, prejudice, stigma. And then I process this with everyone. Remember the domino game we used to play where we would line up the dominoes and knock that first domino. And once that first domino gets knocked, it knocks into the others. So if perception is off and it knocks into bias and bias knocks into prejudice, then it becomes hard baked. Our feelings about and our stigmatizing beliefs become hard baked. And then we end up with stigmatizing laws and rules and regulations, which we would call structural stigma. So we're now getting people to understand what stigma is. Okay, once we've done this, we go to one more video and I'm going to move on. I'm going quickly here because I want to make sure we have time. In this video, people are sharing their stories about their paths in recovery. And so we don't have time to do that. So I'm going to just tell you that that's what we do. But here are the questions that we then process. What makes people want to change? Is there one thing? So we're getting people to sort of open up about what we know about the recovery journey and that it looks different for everyone. And most importantly, we explore what does support mean to each person and how can we ensure that every door is open when someone is ready, right? You can't ask the first question. You need to be ready without us being ready and making sure that all those doors are open. After this, we watch one more video, and the treat here is I'm going to let you watch that video because we've got some time. So we're going to watch this video and then I'll bring up those last couple of questions because I really did want you to see a video.
But I remember waking up from that coma and feeling this peace that I've never felt never felt that peace. And I knew I was done there, I guess. I knew like my brain just felt connected to my body again. Like it felt, I always felt different, than everyone else. I felt disconnected from the world.
Mm.
And I guess that same day I felt like if I connected with self again.
Wow.
I remember in early detox, I was going through a process, and there was this period where I would vomit and I was just out on the floor, shivering, going through withdrawals. And he's all like, I got you. And he was just wasn't saying much, but he was treating me with love. I
So
could
there
feel
was a
that.
peer who was
There was
really
a peer
supporting you.
supporting me, yes.
Yeah.
So I remember telling him, like, why are you doing this to me? Like, you don't even know me. Why are you? He's like, because I was like you 11 months ago.
Wow.
So that kind of caught him. I'm like, and you work here, and this is a detox center, kind of like a hospital. And he kind of started sharing his experience with me.
Yeah.
And I started thinking, like, one day I want to do that. I want to help others. And
So the healing, right? It's myself, my family, my community, nation, and it's a cycle, right? And it's an ever-going cycle. So what I'm trying to do, like I'm in the point in my recovery where I've recovered from a seemingly hopeless state of mind and body, right? So I took care of that and integrate that into recovery at home, right? I'm married to a non-alcoholic, non-addict, but she lives by spiritual principles, right? So we integrate my recovery into the family recovery, right? So my family's in recovery and healing. We have friends, and that's the community, right? So like we keep growing our recovery circle bigger, and then eventually goes up to the nation, right? So if you know that I'm in recovery and that the things that are going on in my life, maybe you see that, right? And it's just like a ripple kind of effect.
I was never able to keep plants alive. They would die on me. I would overwater them, drown them. And that first plant that I was able to keep alive, it's a marigold plant.
Yeah.
And I felt like I was on another step of my recovery because I'm able to be more caring on that part. I feel like externally I can be very caring, but that's more of an internal instinct to water them and care for them.
Yeah.
And now I think I have about 9 plants that are alive and they have been alive. So for me, it signifies that there's growth.
Yeah.
And I'm able to be more attentive, and it's my own growth for myself. So I water it, I nurture it. It's something that I have to tend to. And that's just a reminder for myself because I think I don't do that sometimes.
My experience was I did not get sober alone. I don't think it's really possible. Maybe it is if you had superpowers, but I couldn't. That wasn't me. What worked best for me was working with other people who had similar issues. There was a saying in a treatment program: identify, but don't compare. Like, she's pretty, but I'm not. He's rich, but I'm not. Comparisons don't help. Identify how you feel, even when we're having the same issues. That's when someone realizes that they are having similar feelings, and that's a type of connection. Once you form that connection with someone and you know they've had similar experiences, you can ask them how they got through something. Connect people to each other if you can, and with modern technology today, you can. Even if you're not in person, you can still connect.
It's not easy to get clean and sober. It doesn't happen in one day. It takes a long time to gain the fortitude to get healthy, to be grateful, to be clean and sober.
I, at one time, thought just because I got clean and I'm starting to do things good and right now, that my kids and my whole family they were gonna just come running to me. Good job, good job. But it doesn't really work like that in the real world. It's like, my family's waiting. They were waiting to see if I was going to be consistent, if I was going to stay good and continue to walk on that path. And I just kept doing it because I knew that's what I needed to do for me. And then one day I looked up, and I had my whole team, my kids, my sisters and brothers, my mom and dad, and everybody's on my team. And they're really proud of me today, proud of the things that I'm doing in the community and working with people. And it never ceases to amaze me how much support I get from them.
Beautiful. Okay, so when we're done with this, we're closing up the workshop. And what we're doing here is we're asking this question, how can we continue this work? What can we do now to support people on their recovery journey? So we'll put easel paper up. I'll open it up to the room. We'll write all of those things down. And when we've processed that, we always close with, what are our positive beliefs about opioid use disorder, substance use disorder, and recovery? I was in Kentucky and we did 6 workshops in 1 week. And what I always do at the end of a week is put up all of the easel paper so that everybody can see when we do the facilitation leader, what if everybody's responded during the week. Every single one of those easel papers, the first thing that every group, unbeknownst to the other groups, wrote, it's possible. Recovery is possible. So it's really amazing what we're doing here. And we're getting to stigma in this conversation and sharing these positive stories. I just want to share what we've done so far. We've done 147 workshops. You can see the work that we're doing, but this is ongoing. In the spring, I'll hit the road again. We'll do a virtual facilitation leader in the winter for all of those people who've gone to a community conversation. But we're doing this work and so excited, and we'll be at the HRSA reverse site visit for those of you who have RCORP grants. And there's our contact information. So I just want to say thank you. I'm going to stop sharing my screen so the next person can, but I want to say it's an honor to be here and thank you so much. And I look forward to hearing about and seeing all the work that you all continue to do.
Thank you so much, Tedra. Wow. I just have to say, those sound like amazing, amazing workshops. And you're busy. You're all over the world doing these. So thank you for all you do. And I'm grateful for the opportunity to be here today. So I'm going to share a little bit about the Arkansas Behavioral Health Integration Network and the work that we've been doing. Our work primarily focuses on rural Arkansas. We are a rural nonprofit, and we have been up and running for the past 5 years. We were born out of a CPC Plus initiative, and we had the pleasure of receiving an RCORP grant. Our first grant was a planning grant. And then we moved on. We did receive an implementation grant, and then we received an overdose response grant. So I first want to say Arkansas is a very rural state, and we have a large population that's struggling with substance misuse and primarily opioid use disorders. And we also have a high overdose mortality rate for substances. So I'm not going to go through all of these different numbers, but you could see Arkansas has a pretty significant need for this work. So if we started to work on this project, we started looking at really co-occurring needs for people who are struggling with substance use disorders. And one of the things that we realize is there is often a co-occurring behavioral health need, and it's really difficult to treat those separately. And then we started to think about what kinds of resources are available in our rural communities. And so as we were looking around our rural communities, we did a needs assessment, we were talking to individuals, we really didn't see enough services And we often refer and think about this as a treatment desert in our rural communities. We would hear sometimes people have to drive an hour, hour and a half, sometimes 2 hours to get the care that they need. One thing we do see and we realized is there are primary care clinics in these communities. And there are sometimes community access hospitals or rural health centers. And so at that point, we started thinking about the importance of working with primary care clinics in this project so that we could help address both the substance use needs as well as the behavioral health needs. And as we started this journey, um, it was not all smooth sailing, let me just say. We did, as we talked to our primary care clinics, they were very interested and eager in addressing the opioid use needs as well as the behavioral health needs, but they really had a limited amount of resources and they were reluctant to screen and really brought up some challenging questions of, okay, well, if we do screen in our primary care clinics, how are we going to get services for our patients? And so one of the things, and you can see here on this diagram, really thinking about this from a recovery ecosystem model, and then really thinking about social determinants of health and helping those primary care clinics also address social determinants of health needs, excuse me. So we did lots of different things throughout this project. One of the cool things that happened is we created a While You Wait podcast, and we provided CEUs with this podcast. We thought and I have to give a shout out to my team and just say, I'm the spokesperson here today talking about all of the exciting, innovative work that we're doing in Arkansas, but this has really been a team effort. And we've strategically have people located all across Arkansas, and they're extremely amazing and passionate about what they're doing. So they came up with the While You Wait podcast. So while you're in the primary care exam room, there's short, brief brief snippets and podcast with information that is really relevant and really, really important. We were able to bring in peer recovery specialists and talk to them about what specifically does peer recovery specialists do? What is their role? And we really helped the primary care clinics identify that they do have peer recovery specialists that are resources in their community. And so when they're thinking about, working with the patient who could really benefit from someone supporting them through the recovery journey, we provided them with a list of peer recovery specialists that are in their county, as well as contact information. And for some of those, we even did in-person and virtual connection visits and introductions. Okay. Here's several other things that we're doing that I'm going to talk a little bit about. One of the things, we've had a really big impact. You could see we've had increases in screening, especially screening for depression with substance use disorder, for treatment of opioid use disorder and recovery services. We trained 2,721 people. We put out 10 naloxone access points. And one of the things that I can say, those are up and we're so excited, but that was not easy. It was really having hard conversations in the community with helping communities know that naloxone is needed and it will save lives. And there are people in these rural communities that are struggling with substance use, and we want to make naloxone available. We had lots of different community education sessions about stigma, and ourselves were examining how we're looking at substance use disorder. We have a peer video that it's just a minute, and I'm going to go ahead and play it just because Jeremiah, he lives in a rural community, Arkansas, and he can speak so succinctly to some of the needs that are going on in our rural community.
My name's Jeremiah Wool. I'm from small town Arkansas, St. Joe. It's in Searcy County. We're an extremely rural area. National Forest is what we're surrounded by. We've got the National Buffalo River that goes through there. Generally, out of 132 people, I can't even see 8 of them with binoculars. That's how far rural we are. There's not a lot in between. There's nothing there for as far as jobs and sense, but it's just natural forest. Being a part of a small community my whole life, I've got I've got an ability to really talk the language, to get to the lingo, to understand exactly where the peers are coming from. How do you get down to somebody's level like that and understand that that's the core principles that rural development, rural people have when they're developing? It's this closed-minded, almost in a sense that this is what we do for life. I get to share it and have an experience of like, okay, so like we can talk about the things that are around us in our area, but let's talk about the things that maybe we don't know, that maybe doesn't exist here. What does hope look like? What does a good life stand like? What is sustaining a recovery where you don't even have to have the dereliction that we suffer in the rural areas? My name is Jeremiah Wool. You can reach me at 870-577-1569, or you can reach me by email, jwool@rcozarks.org.
So you can see how important these
My name's Jeremiah Wool.
peer videos were.
My name.
Okay. One of the things that I think was really great about the peer videos is we were able to give them to the primary care clinics in these rural communities, and they were able to play them in their waiting room. And for me, and also listening to the providers, it shares a message of hope. And so these rural communities where there might not have resources they were able to see, we can contact this peer and we can contact the peer 24/7. We did a multi-channel stigma campaign and really blasted this over billboards, radio announcements, social media. It was pretty exciting. Here's just a video or a picture of some of the community naloxone trainings, health fairs, really incorporated this into these rural communities. We included law enforcement, we included chaplains, health communities, first responders, forestry, and people were coming out and they were saying, we don't have naloxone. And so we were able to provide that to them, which was really exciting. One thing, we have a large rural community with Pacific Islanders or Marshallese in a couple of our north central counties. And so we were able to translate naloxone instructions into Marshallese and Spanish and make sure that that was available. And now I'm just going to spend a couple of minutes talking about a program that was really cool. For our overdose response program, we placed 6 peers in 9 different facilities. And I think 7 of them were emergency departments and 2 were primary care clinics. And I have to say, this was more challenging than I think I initially anticipated. And it was challenging because the emergency departments were asking us, well, what exactly will the peer recovery specialist do? What will their role be? And do we really have patients that are coming in that are struggling with opioid use? And I think that for us, it was changing the perspectives of, yes, this is happening in the community, but then having the emergency departments being open to having a peer recovery specialist. I can say, and I want to give a shout out and say thank you to our technical assistants. There were a lot of bumps and barriers along the way that really could have stopped us in our tracks. But with technical assistance, I think we were able to bring resources to our emergency partners that we wouldn't have been able to without our technical assistance. So thank you so much. And thank you to HRSA for providing us. I want to say some of the things that we did, we helped them develop policies and procedures. We helped develop workflows for them. You could see Arkansas, again, I know I said we're a very rural state, but we're also a state that has really been thinking about recovery through often a faith-based lens. And so I think we've been able to, through this project, bring multiple pathways of recovery to the forefront. We were able to really talk about and provide a lot of information and education about medication-assisted treatment. We were able to introduce virtual MARA meetings that anybody around the state could attend, as well as introducing and having peers help bring other peers to meetings and assist with getting their community needs met. Another piece that I think was really cool was bringing some expert workshops and really helping think about what the workflow would look like. Screening for us was a bigger challenge than we thought about. I know there was some hesitation about, well, if we screen patients, one, we're gonna know that they're struggling with substance misuse, and then how are we gonna provide treatment to them? I think that sometimes they were hesitant to ask the questions, thinking they would upset or offend the patient. And so spending some time working through that. This right here is a workflow for the emergency departments. And it was helpful for the emergency departments to really think about and have a systematic way of identifying patients and then referring them to the peer recovery specialist who is there, often on site in the emergency department, but sometimes the peer would contact them afterwards. I have to say, one thing that I thought was really helpful in this project, we did work with the Arkansas Hospital Association, as well as our state office of rural health and primary care. They helped connect us to rural emergency departments, and they really were supportive of our program. They did include a story in their publication about this project in order for us to start to get more traction. And our hope is that this project will grow to other rural communities across Arkansas and other rural emergency departments. So we know that naloxone saves lives, and spent a lot of time really trying to make sure that naloxone was available. And so this is just a brief illustration of one of our peer recovery specialists and the success that she had at Five Rivers Medical Center with some visits. And then a cool thing that we also are doing, and we'll just give a shout out, we do a monthly newsletter, and we would provide this to the emergency rooms as well as the peer recovery specialist. There's different topics, and it's helpful information that's relevant to them, to their work, to what they're doing. And I just have to say, I'm so excited as I think about, and I've worked in behavioral health a long, long time, but as I think about addressing co-occurring substance use as well as behavioral health needs under one roof in primary care settings, for me, it just encourages me to know primary care has really become our de facto mental health system. And it is a central place where people are going. They're bringing all of their needs, including their mental health and substance use needs. And so just want to say that primary care is very well equipped to assist, whether that's starting medication assisted treatment at those visits, whether it's providing them some behavioral health intervention visits. And so I want to say thank you for the opportunity to share a little bit about what we're doing in Arkansas. And thank you again for all the great work you're doing.
Hey, Kim, I'm going to get that slide up for you, Tammy, but Kim, we have a question real quick while I get that slide up. From an oral healthcare access perspective, are there public health programs available for patients who have experienced drug use? And is there some form of oral health literacy to educate them on the importance of oral healthcare in an effort to save lives in rural communities?
That's a great question. I don't have a lot of information on oral health. I can say in the past, I have worked in an FQHC, and oftentimes you'll see the FQHCs that are located across, at least they're located across the rural counties in Arkansas. They do have oral health programs, and there is some information and education that they are doing through those programs about substance misuse.
Perfect, thank you.
Thank you so much, Megan and Tedra and Kim, for sharing your experiences and expertise. We really, really appreciate it. And thank you to y'all for participating in this web event. I hope y'all continue the celebration by sharing your stories and insights. I trust our time together today was inspiring and maybe a reminder of why you do what you do. Helping rural providers, patients, communities, and neighbors become and remain more well. Together, we keep the power of rural moving forward every day. National Rural Health Day may be celebrated once a year on the third Thursday of November, but the Power of Rural movement is a daily part of the rural way of life. There are countless ways to support and contribute, from participating in a health fair to celebrating your state's community star, like Kim. There's a role for everybody. Remember, if you have questions, please email us at info@powerofrural.org. That's info@powerofrural.org. And the presentation slides will be posted on powerofrural.org in the next few days, so keep an eye out. Once again, a heartfelt thanks to our expert panelists and to everyone who joined us to celebrate the Rural Communities Opioid Response Program, or RCORP, and National Rural Health Day. Thank you for your continued dedication and support to helping rural providers, patients, communities, and neighbors become and remain more well, moving the power of rural forward every day. Stay well, be safe, and happy National Rural Health Day. Bye, y'all.